Hello, welcome. I am Julie Love. I direct the McLean School Nurse Liaison Project, which is a program out of McLean Hospital that offers any kind of support that schools need around issues of mental health and behavior in schools. I am a psych nurse. I was a school nurse and I've taught nursing school. And it's officially for the Southeast, but geography means nothing when we're doing webinars, right? So pretty much any school that is enrolled can call me or email me if they have any questions about anything. Sometimes it's about kids' meds or help us make a behavior plan or pretty much anything. And I have the webinars. If you are connected to a school district that is not enrolled, you might as well enroll because the program is free. It's funded by a grant. And so I do not know what will happen when the grant runs out, which happens sometime probably this summer. Hopefully we will get ongoing funding and be able to actually officially expand statewide. But as I said, geography means nothing. I arrange webinars with whoever wants to. You know, school districts usually for their professional development will set me up to do a presentation or a webinar. If you've got a school district out there that's doing live PD, I would dearly love to be doing live presentations again. But I'm also delighted to work with community organizations such as the Norfolk DA's office that contacted me and asked if I could help them do a series of presentations about mental health and how it impacts schools and students and all the staff working in the schools. And so they wanted to be here since this is the first one in the series, but they both wound up getting appointments that took them away. So that's why I'm saying hi, but a future one, hopefully they'll be here to introduce themselves. And I will go ahead and share this polling so you guys can see who else is here, just because that's always fun. Okay, lots of resource officers. I assume that's most of the others. And mostly high school, but all ages. And of course, mostly Norfolk County, because that's who's hosting this. And most of you, this is your first time coming to one of my webinars, which is very exciting. It's kind of depressing because I'm a public speaker. It is deeply depressing to me that this is how so many people are getting to know me. But welcome to my attic. Okay, so as I said, I do educational presentations. I am a consultant available for people to call with any kind of questions or advice or wanting to, a fresh set of eyes on any situation. And I offer resources such as these slides here. They tend to be clustered around the topic, but since this topic is so broad, I just kind of put a lot of my favorite ones on many different topics.
I have about almost 20 different topics. We're going to have 5 of them this spring through this series. And I developed them based on what schools and school staff asked me to develop a topic around. They asked for many years for this topic, and I kept desperately resisting it because I think as adults, you're really entitled to have your education be reasonably entertaining. And it's really kind of hard to make this topic remotely entertaining. But anyway, let's dive into it and see if we can make it be interesting. Since I do give credit, PDP credit and or contact hour credit for nurses and other licensed staff, I do have to disclose my conflicts of interest and anything that I recommend that's outside of FDA parameters. I have no conflicts of interest to disclose. As I said, my program is funded by a grant for now. And so at the end of the evaluation, it will ask you, did I tell you that I have no conflicts? Did I tell you that my program has no conflicts? Yes, yes. And then the last one is, did you see any bias? They mean commercial bias. So if you see any commercial bias, please tell me what it was. Because like I said, grant ending soon, would love to see if there's any place else I could troll for money. And if I mention any meds, I don't think I mentioned meds in this, but rest assured, almost everything is off-label for FDA when we're talking about pediatrics, but that's a separate whole issue. Like I said, not many meds in this one. All right, let's start with a hypothetical kid. Okay, we got Charlie here. Does Charlie look familiar to you guys? He's the kind of kid that we frequently try to figure out what's going on. Okay, so Charlie just moved to town. He's in the second grade. Kind of hard to tell whether he's behind grade level or not, because he will not let anybody actually like talk to him for more than about 30 seconds. He is almost never doing what the class is supposed to be doing. He's trying to be a class clown. It may or may not be working, because if kids don't actually laugh at his jokes, he hits them, which does not make them like him very much, which makes him more upset. It's a mess. And part of the mess is that his teacher is also new to the town, and she's got no idea what is available to her or who she should talk to find what sort of resources she could tap into to help manage the situation that is disrupting her class. So resource mapping is something that you may have heard of. You may have heard of it and then run out of the room as rapidly as possible, because it is pretty much every bit as unpleasant as it sounds. It's finding out, what do you have? You want to find out who around you that you have access to would be good at what, and then how do we get them to be willing to do that? One way to make people willing to offer the services that they're good at is by making it very clear that it's not going to be give them an inch, they'll take a mile situation. So part of outlining who does what is specifying exactly what they will do. Not that they become the go-to person for everything that's remotely similar to that, but this is what they are for. And this is who they are doing it for, so that if you are the go-to person for the elementary school, you don't start having everybody in town calling you. When will you be doing it? So you don't end up on call 24/7. And this doesn't get posted so much, but part of helping the person develop and acquire and be willing to take on the role is helping people recognize when something comes along that is outside of these limits, where can you send them? Because as we know in school, just saying, yep, not my job, go somewhere else, does not work, because they will always just come back to you. Where else am I supposed to go? So how to give them an answer of where else they can go. Once you know who can do these things, then you need to make sure people know it. The new teacher who just arrived in town, you might have a glorious resource map that she just doesn't even know exists for the school. So how do you spread this information around to the people who need it? And then once you've spread it around, when it changes, how do you make sure people have the most up-to-date changes? I think one of the most glorious things ever invented in word processing is having a footer that automatically tells the date that that thing was printed, so that if you got 2 copies of the resource map, you're not relying on whether or not the person typing remembered to put down which one is old and which is the new replacement one. So a sample example, it didn't have to be a chart, but God, I love charts. And I guess rows and columns are just reassuring to me. But you basically make yourself a chart where you list what are the things that we need. That's going to be different for different towns, different communities. Then who's the person? What can they do? Who do they do it for? How do we find them? And when is it appropriate to reach them? Okay. Now, when you look at this, you're like, okay, so do we go from left to right? Not always. It's okay. Which column do you fill in first? If you find that this is the easiest thing to fill in, let's just, look at who we have first. Totally makes sense. It's kind of depressing sometimes when you start with just the needs, but if you start with who's offering the service or who is available to be recruited to offer the service, that is a resource map. If you take the same exact form, but instead you start with the first column and then see what you can do about the rest, that's a needs assessment. Now, if you did this twice and you hold the 2 up and there's gaps where you've got need lines with nothing to write in, that would be the gaps that you need to be dealing with. What do you need to work on? Okay. Whether you're doing it as a resource map or doing it as a needs assessment, it is really no fun at all for anyone. I mean, it's a tedious process that also involves talking to people who do not like what you're asking them. So have a committee do it. Don't make one person be the only one holding this, okay? Or there are resources online that can help with that. There's a couple agencies that are very good at helping people walk through how this works. A great needs assessment is the SHAPE system is put together by University of Maryland. They're becoming like the Center for School Mental Health nationwide. And they have tapped into John Crocker's work up in Methuen. He has recruited like over half the state. And it's kind of nice that they do serve what I do, where I say, I'm offering these services, whatever of them you want to take. He does the same thing sort of on a more administrative level of how to organize curriculum and stuff like that. And he brings all the things he can and gathers what's available out there, and then does not insist on, you must take this. You know, different districts have different abilities to take on new curricula or new things. So, and the SHAPE system is an online way to plug in this sort of information. So it can help guide what sort of information do you want to be collecting about your school to get a sense of what does it have available to help. Okay. Now, once you have an idea of how your school manages, you got a lot of blank lines there. And that does not mean that you draft more staff or hire more staff. It's that you look and see what of these things go in that refer people elsewhere line. Okay. So you do the same sort of thing to your community. Okay, what do you have available around you? Who knows this? How about we write it all down? Okay, so what are the outpatient or the mental health services, both outpatient and inpatient, day programs, support groups, anything like that that you've got? Okay, what are services out there that help families with all the different stresses that you might look and say, well, how's housing or food assistance, mental health? That would be someone who does not work in the field asking a question like that. Of course, all these things relate to how mentally healthy the students you are working with end up getting to be. What community resources are out there, whether it's churches or civic organizations, agencies, and so on. And as I said, when we go online, geography ceases to exist a lot. What sort of online resources can you find and refer people to as well? Once you've got these community resources, now when you want to be sharing them, it's great if you can share them directly to the public. So go ahead and put things like this on the school website so that families know that that is a useful place to go and find the things that they need. Excellent, especially if they're kind of embarrassed or shy about coming forward and asking directly for it. If you are putting stuff on the website, you really want to have somewhere easily noticed and recognized a link to who you should email if you find out that one of these links is broken or went dead, or this program doesn't exist anymore, or this program moved out of whatever. Because it's really any resource list that you come up with almost immediately becomes sort of an archaeological relic of what was available back when you wrote it all down. And you don't want it to be that, but you also don't want to have any person have their job be to keep going out and finding new stuff and testing, do these things work or not? So what you do is you kind of crowdsource it and say, hey, by the way, if any of these links don't work, let us know so that we can update the list. And that way you've got everybody's eyes helping you keep the information current. There's a lot of interest out there in coming up with like one universal, accessible, perfect for everybody list of like therapists. And any list you make becomes obsolete very soon, partially obsolete, and it gets progressively more obsolete. And so when we get to therapists, I'll say one of the ones that I highly recommend is Psychology Today, which is not a plug for them. It's just that because they've gotten so universal, everyone who's anybody posts themselves there in order to get clients. And thus it's kept up to date by the people listed on it, rather than any other list that you've made where there's no way to keep it updated. So you mapped the resources, and Charlie progressed and he's made it to the next grade. He got promoted. He's in 3rd grade now. Okay. He's meeting the adjustment counselor. Okay. And that has helped a lot with his figuring out how to make friends without hitting them so much. Okay. He's still kind of below grade level though. And it's probably because he's all over the map. third grade teacher who's been teaching in that school since like the Civil War, says that he's a poster child for ADHD. So the school's doing everything they can to be supportive of his different learning needs. They've got an IEP, they've got all kinds of, they've got the fidget tools and all the practices. They had one of my webinars so that they know what are the best things for ADHD and so on. Still doesn't seem to be enough for what he's doing, for helping him focus. So what else could help him? Well, how do we help kids who need meds get meds? Now, at this point, my boss said, well, why are you going straight to meds? I'm like, okay, well, I've got a narrative flow here. Okay, we're trying to have this metaphor. Take the narrative of Charlie's life. ADHD is one area where meds frequently are not needed to be tied to therapy as much as everything else really benefits from combination of therapy and meds. And basically, they kind of did do therapy because all these things would be the sorts of things that you would be doing therapeutically, behaviorally, cognitively for someone who has ADHD. And so medications might be something that would be helpful to someone once you've done everything else. So how do we get meds for our kid? Well, first of all, they've got to have a pediatrician. I think they're almost like not allowed in without one, right? So start with a pediatrician, okay? An awful lot of psychiatric issues can be managed by the pediatrician, or at least started there, okay? For some reason, an awful lot of pediatricians think that the brain is like this totally mystical other organ that isn't part of the body that they're responsible for helping with. And so it'd be really nice if they treated the brain like every other organ. If the kid suddenly has really bad asthma, they don't immediately say, okay, I'm not going to see you, go to a pulmonologist, even if there's a 6-month wait list. They would never do that. But somehow, if you got a kid who needs psych meds, there's way too many pediatricians out there who are like, ooh, I don't know how to do that. Go get a psychiatrist. The problem is the wait list for psychiatrists is huge. Okay, and you might want to help the kid before that. So one thing the state has done to try and help with this, to help get the pediatricians to kind of be a little bit more comfortable, is offering them access to a child psychiatrist for consultant, sort of like what I do for schools. And so that is the McPAP program. It is not something for schools to call. It is not something for families to call. But it can be very useful to know about it so that when you talk to the pediatrician, you can say, well, have you tried asking McPAP for help with this? Because they can call, run a scenario by someone and get advice about what they should do next. They can even send the kid into a McPAP office, or I guess they do it online now, but to be assessed by the child psychiatrist. And what comes out of that is not that psychiatrist now takes care of the kid. No, it's just an assessment. And they send back to the pediatrician a letter saying, okay, this is what I saw. This is what I think is going on. This is how you should approach it. This, first and second options for meds going forward. And they will also recognize and be able to say, okay, yes, this is a kid that is complicated enough that you should refer them to a psych professional. Yes, this is getting beyond what you're comfortable doing, and that totally makes sense. Let us help you find someone to refer them to, or let us help you start them on something while we refer them, so that the kid isn't left just on a wait list with no treatment for months and months. If they are getting referred, if you do need to have, down here, you'd really like to be able to talk directly to the pediatrician. Okay, so having a release, technically by HIPAA, the school nurse can talk to the pediatrician because that is continuity of care. If you think about it, your doctor does not make you sign a release before sending your record to the specialist that you're going to next, but anyway, if you really want to be careful, make sure they've signed a release, and then you make sure the family knows that that's not so you can sneak around and talk behind their back. Same thing if the kid's in any kind of treatment, you'd like to be able to talk directly so the parents do not have to be remembering everything you want them to tell the doctor along with everything they want to tell the doctor. They can just go and tell their part, and the doctor can hear directly from the school about what the presentation in school is like. Now, if they are looking for a psychiatrist or a psych NP, someone specialist prescriber, officially you can look at the back of the insurance card and call the insurance, their mental health number, It's officially an option. I've yet to meet anyone for whom it actually succeeded in getting them a provider. But there are online search tools that I will go into in detail when I'm talking about therapists. It's basically the same thing, except you click a different tab looking for a psychiatrist. But one thing you'll see a lot is much more wait lists for a prescriber than for a therapist. You get on every single wait list. Tell them, yes, when they say there's a 6-month wait list, of course that's unacceptable. Get yourself on the wait list anyhow. Put yourself on the wait list. You can also say, can you put me on the cancellation list so that they will call you if there's a cancellation that can move you up. And then you keep calling. If you find someone else that's sooner, great. It's very nice if you call back the first one and get yourself off the wait list. But I've met so many people where they think 6 weeks is, I need help now. I can't possibly wait 6 weeks. And then 6 weeks later, they're still looking. And they didn't sign up on the wait list back on day one because they couldn't imagine still looking 6 weeks from then. So sign up for every wait list. And if you have an appointment, even if it's months out, you go back to the PCP. If the PCP was saying, no, I can't possibly, they may well change their mind and be willing to start then. Because one of the reasons why the PCP might be reluctant to start prescribing is because once you start prescribing for someone, you kind of own them. And if they never go find someone else, you have to keep treating them, even if it really is beyond your ken. And so if you're like, yeah, I could start, but if it doesn't work, I don't know what to do next, you wouldn't want to start. If they know that you actually are going somewhere else in 2 or 3 or 4 months, they might be a lot more willing to go ahead and start and let you show up at the specialist saying, okay, we know that this one doesn't work. What's plan 2? Rather than being at square one 3 months later. Now, if the family does not like the idea of meds and they are reluctant to medicate the child, I don't want to drug my kid. We need to be gentle about this and compassionate. Listen to why they don't want to. I'm very sorry. My phone is supposed to be off right now, and it wasn't. Sorry about that. They are supposed to, they will have concerns. We too often think this person has reached the wrong answer. Therefore, anything that they use to reach that answer, it's also wrong and not worth listening to. No, listen to what their concerns are and address them. Okay, recognize that there's a lot of stigma out there. There's huge amounts of stigma around anything mental health related. And the more we can do to help people recognize it's not that different from a medical illness. And we need to really push back on this whole societal attitude that this is like a world apart and something to be ashamed of, rather than just, yeah, sometimes, you need a little help getting through something. Okay. They also might be very reluctant because they don't want everybody in the school to know that the kid is on meds. So you want to really make it clear to them that you will keep their information private. And then you need to really keep the information private. Someone in the school should know. The school nurse should know. Everyone else does not necessarily need to know. And the school nurse needs to be able to set those limits. If a teacher comes down and says, well, what's he taking? Be able to say, I do not need to tell you that, because that is not something that you need to know for teaching. What you need to know is to tell me if he's got a headache, because I might know that's a side effect of it, but they don't need to know more than they need to know. Okay. Lots of times people are reluctant to take meds because they have misinformation about the meds. I mean, the internet is a very, very scary place. If you go and you Google anything medical, especially anything about meds, especially anything about psych meds, and triple especially if you're looking for side effects of psych meds. So you want to find out what information do they have and gently help them find out if that information is inaccurate or inflated or, looking only at one corner of it and so on. We also want to help them recognize and help everyone in the building recognize that this is not the magic pill that makes everything better. It is one of many tools in the toolbox. And especially if we're talking about ADHD, there are all kinds of skills for kids to learn to be able to manage their attention and manage their symptoms better. Unfortunately, they might not be able to learn those new skills because of the symptoms they have. And so you got this catch-22 going, where there are plenty of people where when they take the meds, that puts them in a position where they can learn better. And much of what they're learning is how to manage their symptoms so that it becomes less and less necessary for them to have the medication because they've got lots of other options as well. And so we want to reinforce the idea that this is just one part of the puzzle. It's not the be all and end all of everything. If they have a bad experience in the past, acknowledge that, yeah, that really sucks. How can we make sure that that bad thing doesn't happen to you again? You know, if they've been treated rudely by someone in the past, that is very real. Do not assume that they were being thin-skinned, and help them make a plan for how to not have that happen again. You know, well, let's find you a different doctor, or how about a different pharmacy, or would you like me to call and talk to them? Through it all, we want to emphasize that we have a shared goal of the kid doing better. We want them to feel better in school, you know, feel better in life, not be so anxious or not be so depressed or not have the distraction and impulse control issues that go with ADHD. I had one student who was agonizing over whether or not to give her son Ritalin or put him on Ritalin. And then she did a day of trial of it. And she came into her next clinical day with me practically in tears. She said the day she gave her son the Ritalin, he came home that day and said, "Mommy, the teacher didn't yell at me at all today." And her heart just broke because she realized he thought it was him. He thought he was just, you know, the bad kid because he's always the one getting in trouble. And so we want to help the kid have the best life and the most success they can. And you make sure that no matter what the answer is, whether it's yes or whether it's no, you are there for ongoing questions and concerns. It's not like, how can I convince you? Okay, I convinced you, I won. Okay, we're all done here. I don't need to talk to you anymore. But no, yes, you're willing to try. That's great. Come and tell me how it's going. Come and we'll keep talking about how it's going. Or you don't want it. Okay, let's keep talking about what we are doing. Because if they see you really trying to do everything else and it's clearly not enough, then they might be more willing to loop back to the idea of considering meds. Because the answer might not be yes. They have a legal right to decline medications. They have a legal right to say, no, yeah, my kid's got ADHD. I do not want to put him on Ritalin. I do not want to give him any meds. And the school cannot say, okay, well, then we're not going to take him. You know, and if you got a teacher who is in the habit of dragging the kid into the nurse's office saying, "Call home, I can tell he didn't take his pill today," that is extraordinarily unprofessional and rude and hurtful to the child and inappropriate and potentially illegal to be basically saying you will not educate the child unless they are medicated, because you can't actually require that. So back to Charlie. He made it all the way to 6th grade. Okay, so unfortunately, as we've gotten to know him really well, it's kind of clear that concentration is the least of his problems. He still isn't really connecting with a lot of kids. He rarely participates in anything. He's hardly listening, and when the teacher goes to get his attention, he, like, you know, practically freaks out and gets very, very angry very easily. He turns on a dime in a second. He's still seeing the adjustment counselor, but the adjustment counselor is like, "I've got so many kids to see. I don't want to wash my hands of this kid, but we're spending an hour a week where he's just sitting there glaring at me. He won't talk about anything. And I've got so many kids on the wait list. So what can we possibly do?" Well, therapy would be a really good idea. And as I said before, there is no magic referral list. Everyone thinks that my role in the universe is to provide for them a magic referral list of therapists who call you right back, take all insurances, have no wait list. No such thing, sorry. And like I said, if anyone did manage to write that down, it would almost immediately be very less useful. Okay, but there are things out there that you can use. Okay, one thing is, for anyone on Mass Health, there is the Children's Behavioral Health Initiative, CBHI. They've got a variety of things. They try to do wraparound services, so it can be family therapy, in-home therapy, therapeutic mentors, case management, all kinds of great stuff. It is for Mass Health. They've been trying for years to make it also available via private insurances. The sticking point, though, is the therapeutic mentors. Since they are not licensed professionals, private insurance cannot figure out how to pay for them, how to enroll them in insurance programs. So it's out there in limbo for years now. Okay, these two websites, and as I said, I think I sent you guys the links already. So you've got all these links in that email I sent you. But there's one that describes services and one for how to find a provider. I'm pretty sure the PCP can make a referral. I'm not sure who else can, but the information is all right there. And again, on the back of the insurance card, there is a phone number that is theoretically something you could call. But more useful out there, there is the interface program, which is trying to they're not trying to make this, archaeological record of who is available. They will help the people make the appointment. You call them and they take down the information of the age of the kid, the issue they've got, what transportation is like, what their schedule is like. And then they do all the calling around and get back to the family with an appointment. So it is a glorious thing. It's paid for by towns paying a fee for it. So the enrolled communities varies. And I've got the list that I looked up yesterday. This isn't all of them. These are just ones that have had any contact with my program. And so if your town isn't on that list, it's worth going to their website to see if I just didn't know that you were going to be here and thus didn't know to put your name on there. The list changes depending on whether or not the town stays enrolled. Pembroke used to be on the list and now it isn't. I can only assume that they disenrolled for whatever reason. But as I said, they're a wonderful, wonderful resource. There's also other web pages where therapists can sign themselves up and say, okay, yeah, post my stuff there. There's a reason why every therapist's office on the planet has magazines in it of Psychology Today. It's because you get the magazine for free when you sign up on the webpage. And like I said, at least around here, everybody who is remotely considering taking clients signs up for Psychology Today. And so that is a very good comprehensive list that keeps itself fresh by having the people on it keep it fresh. And it's got a filter mechanism on it. So along the side, you can filter based on the kid's age. You get into it with your how far you're willing to drive and your location. Though just about everyone now does telehealth, so that doesn't even matter as much. But you put in the kid's age, you put in their issues, you put in what you want, and you can put in your insurance so that you can screen the list down to ones that take your insurance. The glitch in it is that as you're scrolling through all the hits you get on it, at some point, there'll be a little easy to pass by line that says, that's all the ones who take your insurance, but below are some more people. If you don't see that line, you look like, and you think you got like 50 hits when you end up calling them and they're like, no, I don't take that insurance. I never have taken that insurance. So you have to really look to catch when you've run out of ones that take your insurance. And at that point, you decide, am I going to pay out of pocket or maybe drive farther? Like I said, with everyone doing telehealth. And hopefully we will manage to not let insurance companies claw that back when the pandemic ends. And we might be able to continue to do telehealth indefinitely. That makes transportation and location less of an issue. But, and then people will start with this one. I put it last because it really ought to be last, because people will get a name from their aunt and call that person, and that person isn't taking clients, and then, well, there's nothing I can do, so they don't keep looking. And the person your family is sending you to, you might not really want to be going to the same person that someone in your family is. So, and the PCP totally does not screen for insurance. I've had so many people call my practice saying, well, so-and-so sent me, and they clearly think that I know their doctor, And it's like, no, they just found me online to save you the bother. So keep in mind, people keep thinking that if we got this magic referral list, that would solve everything. No list, no matter how perfect, will ever be long enough because there's just not enough providers out there. So that is why there are wait lists. That is why it is really hard to find one. And we want to recognize how hard that is and how much it's not the family's fault. So we want to recognize that as we tell the family, go and do this. Oh, cool. Email me that link. Someone just sent another link, and I will add it to, actually send it to all panelists and attendees so that everybody can see that link that you just put in chat. Because she sent it just to me. But there's another link for referring people to social workers. Okay, so recognize that the task you've just given this family, who are probably already pretty stressed out based on the situation they're in, is a very frustrating process. Okay, they should, whatever list they're looking at, they should start with at least 5 or 10 possibles. Okay, because just on your first call, you're going to get ones that don't take your insurance, or they aren't taking new clients, or they just never call back. If they don't call back, you can call them again. Trust me, I'm among the people where it's luck of the draw whether your phone call comes in on a day when I have time to call back, or whether it falls into the mean to call back and then forget pile. So, but as I said, any wait list, get on the wait list while you keep looking. Once you find someone, then you want to go for about 3 times to decide whether or not they're a good fit. This is another reason why I'm not really into the recommending someone, because if I recommend someone, that's someone who fits my head. We definitely know there are some people that you want to avoid, but if I've got someone who's really good for me, they might not be really good for you. What we need is someone that fits the person going there. And when it's a kid, they've got to kind of fit with the kid and also with the parents, because kind of either half kind of has veto power here. So what you want to do is go and try and see how well you fit. I tell people this is kind of like clothing. You go to the store, you try something on. If it's too tight, you don't say, well, it's all I got, and go around wearing pants that don't fit for the rest of your life. You also do not decide, okay, well, no clothes for me then, and take them off and go without. You just keep looking until you find one that's a good fit. And I know it's frustrating, because after you've gone through all of this, once you get to this, you're like, yay, I win. And then you find out, no, got to go back to here. It's very frustrating. When you've got a kid, especially a teenager, you need to make it very clear that if they don't like the therapist, that's fine. They aren't going to necessarily have to keep seeing that therapist, but then we're going back to step 1 and finding another one, because kids will think, oh, well, if I just stonewall enough, if I just refuse to talk to anyone, they'll give up and I don't have to do therapy. So you want to make it really clear that no, it's going to be that we'll just keep looking. And sometimes you got to go through a couple therapists before the kid realizes that, yeah, you actually do mean business. You're calling us bluff. At which point the kid might even say, yeah, that second one a month ago, they were okay, and might loop back to them. Okay. Comfort level of the child and of the family matters more than whatever letters they have after their name, their credentials, or their therapeutic philosophy, depending on the issue you're working with. You do want to make sure that they have experience with the age of the client and with what the kid's working with. If you've got someone who's really good with anxiety, they may or may not be that good with someone who's got ADHD, that sort of thing, though. Lots of things do go together. Now, if you don't know exactly what we mean when we say credentials or therapeutic philosophy, there's lots more on both of these, but the most common ones you'll see are things like licensed family therapist, licensed social worker, licensed independent clinical social worker, mental health counselor. I should change that to counselor, shouldn't I? Because there is a C. Sorry. Psych NP, that's what I do. Psychiatrist. The 2 with the asterisk, the NP and the psychiatrist, they are the ones who can prescribe medicine. Okay. Psych NPs also do therapy. Psychiatrists might, but generally there's so much pressure for them to just do the meds that pretty much that's what they do. One thing you might run into is if there is a group practice with a bunch of therapists and a couple psychiatrists, they might insist on working together so that if you're just looking for meds, you know, if you found a good therapist, but now you want meds for the kid and you call that practice, the psychiatrist might say, okay, yeah, but they have to be seeing one of the therapists, one of my colleagues. If you got a therapist that works, don't let anybody force you to leave them. You know, if you've got a good connection there, it's worth making more phone calls to find a psychiatrist or psych NP that does not require you to dump your therapist and sign on with one of their colleagues. I mean, it makes sense that in their practice, they want to have that communication going. It's not that they're like just doing it for the money. It's how their practice fits together and works. And that makes sense. But there are plenty of other people out there who do not require you to be working with one of their colleagues. It's just harder to find them. Okay. So, and you might see all kinds of other letters. Frequently, they add more letters when they get certification in like substance abuse counseling or various other things. Now, when it comes to therapeutic philosophy, that's what are they doing? Okay. And I've had people who call up and say, do you know anyone who does CBT? I would be hard pressed to name anyone who does not do CBT. Okay, CBT, cognitive behavioral therapy, is basically therapy. It's the idea that if we talk about the thoughts and the behaviors that are interacting with your mood, it's like the three sides of the triangle: how you think, how you feel, and how you behave. And they're all connected and they all influence each other. So we're going to be working through these, and it's frequently focused, not exclusively, but primarily on what's going on now. You know, if you want to sit and lay on a couch and talk about your dreams and your childhood, that's psychoanalysis, which pretty much no one does, but it's cute, so I put it on the list. But CBT is standard therapy. The rest are kind of variations on it. DBT, dialectical behavior therapy, is a subset of CBT that's very good for emotionally explosive people. It's designed for borderline personality disorder. EMDR is something that sounds utterly bizarre and totally quack, but it's not. It is a specific therapy for PTSD where the person will, while they're recalling their trauma, move their eyes back and forth. Or they might have headphones making a sound in alternate ears, or the therapist might stand behind them and tap their shoulders while they're talking about their trauma. And that's supposed to somehow help. The thing is, it does. They've got all kinds of science showing that it does. And we kind of understand neurologically why. It's because the memory center is right in the middle, all the way in the middle of your brain there. And every time you remember something, you rewrite the memory. It's like making a Xerox of a Xerox of a Xerox. And if you increase traffic through the bridge between the two hemispheres, thus you're kind of getting in the way of the Xerox machine a lot, it doesn't make as good a copy when it's remembering it. I mean, it's not like you blank out the event, but what it's most likely to leave off of the new copy is a lot of the emotional, a lot of the fear. And so you can end up taking the fangs out of a traumatic memory by having something bilateral happening while you are recalling the memory. So it's very cool. Positive psychology, if I had time, I'd study more of that because it's very cool. It's kind of, let's talk about happy things and it actually helps you be happy, except that's way too simplistic. I really should not even try and talk about it unless I've studied it more. It's an excellent, excellent philosophy that is very, what are the things that are good? And let's do more of the things that are good so that the goodness can spread through more of your life. Play therapy is what you see more with the little kids. And that's where parents are like, this seems like a waste of time. He just goes and he plays checkers with his therapist once a week. It is important. You know, kids, when they're very young, express themselves through play, not through sitting there talking to someone while they sit on a couch. So for younger kids, you are going to have play therapy. And sometimes it won't be, it's not going to be every single week. Yes, we were playing this and this is what we uncovered. No, it's not like that. But as things come up, the therapist is there to help deal with them. It kind of lubricates the conversation. I highly recommend if there's a kid who's got a trauma history, it's really good to get them into therapy and let them just stay in therapy without it being, well, when are they going to open up? They might talk about their therapy or about their trauma? They might not yet. And what you want is to have them have a secure relationship with the therapist so that at whatever point it's time to actually be talking about this, they've got someone to do it with that they don't have to look at across the dinner table. It's sort of like getting them well connected to a kind of disposable, discardable friend, where it's someone they can trust enough to tell these things to without feeling like, yeah, but every time that person looks at me, I'm going to know that they know what was done to me. That can be a big barrier to talking about stuff when the kid's ready to talk. So it's very good to have them have a therapist. And it might be that they start off just playing with the person, possibly for months or years. So art therapy, similarly, you're expressing yourself through visual arts. ERP, exposure response prevention. This is key for OCD and anxiety. It's basically that thing that you're running away from because it makes you anxious. We're going to help you move towards it instead. We're going to make you touch the doorknob and not let you wash your hands for a while and help you retrain your brain. Because every time you respond with tremendous fear, you reinforce the message in your brain that what you did is really scary. And so if we help you keep doing it until your brain is just too tired to feel scared so much, it starts training your brain to not being scared of it. Motivational interviewing is an excellent way of helping people explore their own ambivalence about something. It's wonderful for teens. It's wonderful for substance abuse. It's wonderful for anyone who needs to be making a decision. And it's helping them make their decision instead of us coming along and telling them what the right answer is. And then ACT, actually, yeah, I wouldn't study positive psychology. If I was going to go get certified in something, it'd be ACT. This is taking this idea that people have of you go to therapy so that you can get better. And then when you don't have those symptoms anymore, you get your life back. ACT says, well, what if you never get rid of the symptoms? Wouldn't you like to have your life back anyway? How about we just give up on getting rid of the symptoms and figure out how to go ahead and start living now? As a side effect, and they hasten to emphasize this is a side effect, not a sneaky backdoor into solving the symptoms do tend to get better, but that's just a side effect. Their goal is to let people proceed with actually having life, even if their symptoms are still there. And it's brilliant. It's wonderful. So again, family might not want to do it, and we need to be compassionate and listen to people when they're reluctant to do something. We've got to stop coming in with the, well, can't you see your kid needs help? You know, address the stigma, address whatever else is going on. Address the emotions the parent might be having. You know, most of them probably feel having a child who needs therapy is tangible evidence of their failure as a parent. Okay. Also, lots of times they look at the kid and say, well, he should just stop doing that. You know, whatever he's doing, it's just behavior. And so if he would just stop doing that, then we wouldn't have a problem. He's just trying to do this in order to get attention or bother us or whatever. And if we take him to a therapist, that's just going to reinforce it and reward it. And we want to help people recognize that, okay, manipulation is doing something to get your needs met. And what kids tend to be doing is trying to get their needs met in any way that they can, because they do not yet know better ways to get their needs met. Therapy is a great way for them to start learning healthier ways to get their needs met. Okay. Another real good thing to point out to the parents is that if you got a lot of family conflict going, the kid will reach a point where it feels like will not, but pretty much they cannot go along with what the parent tells them to do. But if the therapist tells the kid the same exact thing, now they can take it in. And if you've had kids, you know that there are things where you really just need someone else to tell the kid that that's really gross and they should stop doing it for them to stop doing it. And so helping them potentially see the therapist as someone who will help get the kid to be making the changes that the kid is not currently able to make. We also want to recognize that whatever barriers they see are real. Okay, we don't say, yeah, but you just got to do it anyway. if it's hard to fit in the time. Time is a really tricky one because when your life is utter chaos, it feels like, how can I possibly devote an hour a week to going to therapy? And the weird thing is, once you start doing that and it starts working, everything else gets more efficient and you end up with more time. Because you can't really recognize when you're in the middle of the mess, but a lot of your life is very much slowed down by the fact that you're having all these issues. And as the issues start to be getting dealt with and resolved, a lot more of your life works so that you end up having more time for things. Okay. We also want to recognize if they've had past experiences that were bad, acknowledge that and help them develop a plan for how to feel secure against that. I have one client who's reluctant to look for a therapist because every therapist she's had has left the practice for whatever reason within like a year. And she's like, I don't want to do that again. I'm like, okay, so when you go to talk to a therapist, tell them this. Tell them that you really don't like that. And let the therapist say whether they are in grad school and looking to move or, and thus, put that out there. If you got a therapist who's like, oh yeah, that would be really upsetting. And just say, I got a mortgage and 3 kids in school, so I'm not going anywhere. That could be reassuring. So it's weird, but it's generally possible to agree with practically anything they were saying about how impossible it is and still make a persuasive case for them proceeding with therapy. Again, you're emphasizing things getting better, improvement and success. Call me with any specific and I can help you navigate how to agree with them while also correcting and steering them in a different direction. Okay. But if they say no, they have a right to decline therapy. Okay, Charlie, remember Charlie? He's in 8th grade now and he had a growth spurt from hell. He is now super big and he has no impulse control and he kind of hits things a lot. Keep calling home, if you want to send him home or they don't even answer. They don't call back. It's a black hole trying to communicate with the family. He doesn't have a lot of friends, but the friends he has, they do care about him. One of them came and said that they're really kind of scared. And I saw Charlie it looked like Charlie was crying. And then he was hiding something and the kid doesn't know what, whether he might be about to hurt himself or shoot up the school or anything in between those two extremes. He's worried and he doesn't know what to do. So how do you get someone hospitalized in our country, in our state? Okay. One thing to recognize is that the system is, it sucks. Okay. This graphic here is one that I made when I was teaching nursing school. It applies to adults, the adult system, and it actually includes a lot of forensic stuff because I did clinicals at the Shattuck where we had a fair number of forensic people. You can request it if you want. It's kind of fun. But basically, if it looks like it's a tangled mess, that's a perfectly good takeaway of the message here is that navigating, accessing inpatient care is a tangled mess. We start with the fact that in any other medical issue, if you've got an issue that's kind of brewing for a while, you could say, yeah, my knee, it's hurting more and more and more. I'm going to need surgery on it sometime in the next month or 2. Let's find a time that fits my schedule where the doctor I like and the hospital I like has an opening and you're not allowed to do that, even though you can kind of feel the same thing going on with mental health. It can be, yeah, things are just getting worse and worse and worse, and we see a hospitalization in the future. You don't really get to plan ahead and schedule it. What you do is you wait until it is an acute emergency, because the threshold for inpatient hospitalization is that they are an imminent risk, like not sometime in the next few weeks, but could happen at any time, of actual danger, risk of harm, grievous bodily injury or death to themselves or someone else. The obvious one people think about is suicide, and thus we need to assess, because people will have suicidal thoughts without being imminent risk. So we need to assess how strong are the thoughts? Do they have a plan? Do they have access? And are they current thoughts, or have they thought this in the past? What do they have of protective factors, and how strong are those protective factors? What do they have that anchors them to this planet, and how reliable is that anchor? But other things count as well. You know, if they are planning to kill someone, yep, that could work. But also it could just be if they are liable to just punch whoever's nearby. If they are generally impulsive, aggressive, hostile, that can work. You can also be hospitalized for being unable to take care of yourself. You could have someone who's got bipolar disorder and they are manic and they have not slept in a week and haven't eaten in 3 days. They're having a blast. They're out in their backyard building something. That would count too, even though they aren't intending to hurt themselves or anyone else. The fact that they need to eat and drink something at some point or their body will collapse counts. The problem with inability to care, you know, that's where you get someone who's like psychotically wandering into traffic, that sort of thing, or they might sleep outside in the winter, that sort of thing. When it's a kid, society turns and says, well, that one shouldn't really apply because after all, the parents should take care of them. So if you've got a kid where, yeah, they could impulsively go out of the house in the middle of the night, society has this really blithe assumption that the parents should be able to prevent that because I guess they think parents never sleep. It's very bizarre. So it can be tricky making the case for that one. It kind of depends. If they're getting assessed and they are considered hospital level of care, they now are determined to be an imminent risk of danger and therefore they cannot leave. The parents cannot change their mind and take them home now. In one fell swoop, the moment they get what they've asked for, they have their rights taken away. It's not a pleasant process, okay? If, on the other hand, they're screened out and they're deemed not to be hospital level of care, well, you get to take your kid home now. Did you have fun for the last 15 hours in the ER? Go home now. Good luck to you. So it's a messy process, okay? The assessment that they're doing, how do you even get a crisis assessment? Well, there is calling mobile crisis. We always say, hey, you can call mobile crisis. Mobile crisis will come to the person. And in theory, they remain involved for a week. If the person is not screened in, they would still be able to come back and check on them or help hook them up. You know, it sounds like a wonderful, wonderful program. I've met very, very few people who wax nostalgic about the contacts they've had with mobile crisis, though. I mean, you just start with the fact that, yes, people on Mass Health, they have access to mobile crisis. People who have no insurance, they have access to mobile crisis because it is state funded. Some insurance plans also contract with mobile crisis. Some don't. Does this kid? Who knows? Let's go look in the files to figure that out while they're in the middle of a crisis. It's ridiculous trying to even figure this out. Saying, okay, I got time. I wrote to all the mobile crisis people saying, could you give me a list of what insurances you take? And I couldn't even get that with all the time in the world to wait for the answer. So it's problematic, okay? What is always there, and they figure out the insurance for you, is the emergency department. So the other option is you go to the local emergency room. The parents can even take the kid to the emergency room if it is safe to do so. You know, if you've got someone can sit next to the kid in the back seat while they are crying, fine. If it's just you and that kid looks way too likely to try and jump out of a moving car, do not even try it. Okay, so if it is safe for them to do so. If it's not safe, you call an ambulance. That's what they're there for. You might also call an ambulance if you're not entirely sure the parents are going to follow through on going to the ER when you have them come to pick up the kid. And if things are just getting really chaotic really fast, that's when you call the police. Or I guess a lot of my audience are the in-house resource officers that would already be tapped into the system for us. Another way to get assessed as hospital level of care is if they have a therapist who says, yep, they should be hospitalized. they would still tell you to go to the ER. But at that point, depending on the provider, depending on insurance and yada, 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 it might just be to get medical clearance and you don't have to wait for the assessment to come and so on. Because like you go to the ER, depending on the ER, they might just keep you there while they wait for mobile crisis to come to them, you know, if that's what the provider is. And insurance, it's so bizarre. Insurance will say a person from this team, but not that team can assess this person. It's not a great system. And the thing is, once they are determined to be hospital of care, that's when they start looking for a bed in a hospital. And so there's a reason why people end up stuck in the hospital for days, sometimes weeks. It's in the ER. It's not great. So, as I said, if the crisis assessment says yes, they are hospital level of care, that's when they start looking for a bed that is available in a hospital that takes the family's insurance and that will take this kid, which is where people get very twitchy about, well, how can they say no? Trust me. If you're used to a medical hospital, you admit anyone because everybody stays where they are. In a psych hospital, everybody's interacting, okay? And I've been on the receiving end where it's like, yeah, if we bring from the description, if this kid comes into this unit with the kids we already have, it's going to explode. It's not going to be safe for anyone. And therefore, I can't say yes to this proposed admission. So it can take days. Now, if they come and say, okay, we found them a bed at, and name a hospital, and the family really does not want the child to go to that hospital, for whatever reason, it might be that they have heard specific things about specific hospitals that are often extremely well grounded. They can decline that hospital and say, keep looking. No one likes it when they do that, and they will do everything they can to make the family think that they can't do that, or to really make it hard for the family to do that. They have even on occasion said, well, okay, then we'll just unsection them. We'll decide that they aren't hospital level care after all and send them home with you. But if your kid's like been to a given hospital and it has gone very, very, very badly, it can be worth it, especially if you say why that hospital is not an appropriate one for you. Once they find a hospital, the child is transferred via ambulance, which depending on their health insurance might cost them an arm and a leg. But because they are now deemed hospital level of care, even if everybody agrees, including the kid, that they want to go to this hospital, the parents are not allowed to be the ones transporting them because they have to be under supervision, professional supervision for the transfer. As I said, the parents lose a lot of their rights at this point. And even if they came in enthusiastically wanting this, by the time they are done with this process, they might be extremely hostile towards the hospital, the ER, all the care providers. It's frequently, we get people who started off in favor, and by the time they're talking to us, they can barely keep from hitting us. So if, on the other hand, crisis assessment says, no, they're not hospital level of care, they might recommend alternatives. For kids, there are a couple other levels. With adults, it's pretty much inpatient, not inpatient. There's day programs. There's saying, hey, they need more outpatient therapy or they need outpatient therapy. But if they're not getting hospital level of care, they're going to be going home. And if they're going home, they're probably coming to school the next day. And then the school's calling me saying, what do we do? This kid, we sent him away yesterday and he's back. And one thing is to recognize that that might actually be the best place for them. Okay. If they are depressed and the thing that keeps them planted on the planet is staying distracted enough by daily life to not think about how depressed they are, and they will get into a program in a few days, having them sit at home and contemplate their future in isolation is not going to be helpful. So sometimes home is really, and nowadays I have one school calling about a kid where it was recommended that she go into partial hospital, and arguably she was better off coming to school because nowadays partial is online. She would be sitting at home alone online doing, let's unpack your baggage and look at all your pain. That's not necessarily something that would be best for her. I always get the calls of like, how could they possibly not have hospitalized this child? Well, the assessment, the people do, yes, sometimes the people doing the assessment are just objectively wrong. Okay, right there with you. Okay, but even the good ones, they only have what they have to work with. Okay, they are basing their assessment on the information they have. And you could have a kid who is threatening all kinds of dire things, and the parent picks them up, takes them straight to the ER obediently, and the parent and the kid are like, I don't know. Why did they want you to come? No, I don't know. He seems fine. And kid's like, yeah, they're just overreacting. I don't know. You know, if that's all the information they have, that's all the information they have. If the school can call ahead and give them some more information, that's kind of good. That's where nurses have this wonderful thing called a nurse to nurse, which is whenever you're transferring a patient, like from one floor to another floor, the nurse from one floor talks to the nurse from the other floor. And thus continuity of care again, they can call the ER and say, hi, we're sending a kid to you. We just want to let you know this is why. And then when the parent, if the parent's transporting them, you say, hey, we called ahead so the ER knows you're coming. Then it makes it a little bit harder for them to decide not to show up. Plus, the ER gets the information. If they've got radically different information, it's still down to who do they believe. There's also the chance that the kid might not be hospital level of care. Okay? Hospital level of care is imminent risk of harm due to a mental illness. Not every aggressive, violent act is connected to mental illness, okay? They would be going to the hospital in order to treat the mental illness that is causing the violent behavior. If they do not have mental illness causing the violent behavior, then you're just treating the hospital as a dumping ground. And I totally get that the end result is that the school ends up being the dumping ground, which is not okay either. But that is why you might get a kid who's threatening things, but it's not due to mental illness. It's due to they just are pissed or whatever else. So the purpose of someone getting hospitalized, reason why hospitalization is there. First of all, the threshold is imminent risk of harm. So step one, priority one, sometimes we never even have time to get to priority two, is keep bad things from happening, keep them safe. Okay, just prevent harm to themselves or others, which is not a small thing. The kid is now safe. The parents, who in all likelihood have not slept in weeks, get to go home and sleep. And a lot of the conversations I have with families in this situation is, it is okay for you to go home and sleep. It is okay for you to go home and feel relieved. That does not mean that you're like dancing for joy. Oh boy, my kid got hospitalized. I'm so happy. No, we know that you are upset, you are sad. This is a horrible thing and you feel very bad about it, but you also have a tremendous weight that has been taken off of your shoulders and put on some professional shoulders. You're allowed to recognize that breathing a little bit easier is a good thing. Because the kid's coming back in a few days, so you might as well get the sleep while you can, okay? The downsides to safety is that a lot of the things we need to do, like I said, the patients they aren't locked in their rooms. It's a community environment. Milieu therapy is our way of saying, yep, they all can walk around and talk to each other. So we have to keep the environment safe for everybody. So this person might have absolutely no interest in hurting themselves, but we still take their belt away. They'll be like, what are you talking about? I wouldn't strangle myself. Yes, I know. But wouldn't you feel bad if your roommate came and stole it from your drawer and strangled themselves? So we search everybody in detail before they come in. And whenever someone visits, we have to search everything they're bringing. We collect and do not let them keep, or we very much regulate their access to sharps. And sharps are anything that could be used to be dangerous by very creative people. I mean, I live in a world where a plastic bag is called sharp, okay, because that's what sharps are. After 9/11, when people are like, why are they collecting, nail clippers? What? You can't do anything harm. I'm like, I know people who could make a razor blade out of a paper clip, so do not go there with me. But And then there's also checks. The other thing we do is someone goes and looks at every single patient at least every 15 minutes, more often if we're concerned about them. And that can be bothersome that someone is, knocking on the door and sticking their head into your room every 15 minutes while you're in there. Another thing that inpatient care can do is starting them on meds and adjusting the meds way faster than you can do outpatient. When I'm starting someone on meds, we start very low and we crawl very slowly because I want to see them before every increase. So they might only be increasing the dose every couple weeks. Inpatient, you look at what is the fastest safe titration, and we'll do that. So we could get them up to full dose in a matter of days. They also might be putting them on meds as part of the safety and containment. A lot of the meds inpatient are really sedating in order to slow the person down, help them have better impulse control and be less likely to be violent, okay? If they are on hospital level of meds, it's not that they're supposed to stay on that many meds. It might be that, yes, they need that much sedation for a couple weeks. And then as they're stable, we start to prune those away. Ideally, unfortunately, insurance doesn't let them stay there a couple weeks. We will talk about the problems that comes with that. They also are introduced to various therapeutic approaches. They are not introduced to a therapist. The point of a therapist is that you have an ongoing relationship with them. You're not having an ongoing relationship with the staff in a short-term inpatient hospital. So you've got groups and you have check-ins with people, but it's not, and we'll have people who are like, well, why am I not having therapy? It's like, because we're really just doing check-ins here, okay? Ideally, you do leave ready to go to therapy, referred to continue with an outpatient therapist. Used to be that the social worker in inpatient unit was like a miracle worker. You would leave with an appointment with your therapist in hand. Nowadays, I see more and more families leaving with a list of people for them to call because, as I said, there's just not enough providers out there. So there are, as I said, alternatives if they are not hospital level of care. CBAT or ART they look a lot like inpatient because the kid does sleep there. It is 24/7 and they're there for a couple weeks. They do go in through the ER, but they might also go there from the inpatient unit if they're no longer critically dangerous, but still could use intensive therapy. They go there. This is a place where everyone can maintain their safety. We don't have knives lying around. It's still a secure environment, but it isn't as tightly regulated as inpatient. And they are expected to at least be able to say that they will work on their issues. They have to at least be able to fake it. If they're not engaging in the program, then we're like, we got other people that could be using this space. And if they are not safe, they go back to inpatient, okay? Partial is a day program, 2 or 3 weeks long, and it's during the day. They go home every evening, except now they stay home and do it online because there's a pandemic. People can refer their own kids there. There's almost always a wait list. The assumption is, yes, you could use work on this, but you got to wait. It might be a wait list that is weeks or months long, okay? But again, they're going there to do work. Generally, the day is structured where half the day they do school. Schools send the work and their tutors there to keep them from falling behind in school. And the other half of the day, they're doing therapeutic programming. And then there's IRTP, which is months and months, if not years. This is a residential program for DMH involved clients. Not going to really talk about DMH. You get into DMH by getting hospitalized enough times that Mass Health says we need to do something about this. And so after repeated hospitalizations, a person can be referred for DMH care, and then they have a case manager and access to things like this. Now, when they are discharged, which might be 3 days later, it might be 3 weeks later. In an ideal world, you leave the hospital with prescriptions to have 30 days worth of meds and an appointment for someone to write a new prescription when you're about, within that 30 days. And you've got an appointment with a therapist. Maybe you already have a therapist, but they've made sure that your next appointment with them is all ready to go in the upcoming week. If you didn't have a therapist, they found you a therapist. And you now really kind of understand more of what's going on. You've got some insight. You've developed some beginning coping strategies. And you kind of feel like, good, finally we're dealing with this. We've been sweeping these issues under the rug for so long, and now we're taking it seriously. We're on the path towards success instead of just downhill, no brakes. Unfortunately, the world is not always ideal. Any of those things certainly could happen. Some of them don't. Sometimes you leave without anyone new to prescribe the meds. And so you're going to the pediatrician for the meds, and they think the meds the hospital ordered should be the kid's meds forever, because who are they to say something different from what the hospital did? So you take the pile of meds that are necessary to slow the kid down when they're critically, violently struggling, and the pediatrician just keeps them going indefinitely. You know, I've had many times when school nurses call me and they're like, and here are the meds the kid's on. I'm like, oh, when did he get out of the hospital? And they're like, how you know he was in the hospital? I'm like, because of those meds. They are what you get in and for maybe a few weeks after you leave the hospital. They might have an appointment with a therapist that is months away, or a month at least. They very frequently feel like, okay, all that this accomplished is now everybody knows my deepest, darkest secrets. No one's willing to actually help me fix them. But now I can't run away from them, but I also can't progress on them, and everything is actually much, much worse. Plus, they might have picked up a few tips from their roommates. Lots of people learn things like self-injury by seeing other people do it. And it's not that people are like recruiting. It's, you know, you see your roommate with marks up and down their arm and you're like, oh, why would you do that? And the kid says, when I feel bad, it makes me feel better. Next time I'm feeling bad, I might be like, what do I got to lose? And if it makes me feel better, I've got a new maladaptive coping strategy. And it does not help that now they come back to school where everyone is staring at them saying, where have you been for 2 weeks? And all the teachers are, okay, here's the homework you missed. You know, because yeah, the school was sending the assignments for the tutor in the hospital to give them, but you know, the kid was a little bit busy in the hospital. Their brain was probably very, very occupied with dealing with the fact that it was healing. You know, if the kid had been in the hospital in a coma for 2 weeks, I don't think the teachers would be turning around and saying, but I sent the assignments, why aren't they done? We got to help the teachers understand that, yeah, same thing could apply if the brain was really, really busy doing something else while they were in the hospital, and coming back to the expectation that they will do every scrap of work that they missed is not okay. So they're coming back, okay? Communication is key now for things to be successful, okay? It's really good if you've got one person who's the point person, the bridge between the school and everybody on the outside, providers, social workers, therapists, family. That only works if that point person is also talking to everybody in the school. They are not the person who hoards the information. They are the person who disseminates the information. But that way, everybody knows who's the person to call if they've got information that needs to go across the bridge to the other side. You should generally have a school reentry meeting. It is a chance for everybody to plan on how to proceed so the kid can come back and be successful. Many schools now have bridge programs. I should probably put that on here. Some schools don't, and the bridge programs vary very much, but it's trying to have a place where the kid might come and be in sort of a sheltered school within the school for the adjustment back, okay? But the main point of the entire process, the reentry meeting and everything, is to communicate very clearly about what is really going on, because everybody comes into it thinking they already know. Everyone comes in with assumptions, okay? So you want to find out what actually are the challenges that we need to help the student overcome. You know, do they have symptoms that might come up during the school day? Do they have triggers that they might encounter during the school day? How can we help them navigate the minefield that is the day, okay? And how do we help them with that? What sort of things are helpful to them when they're dealing with this? Do they need to have a heads up if there's going to be a fire drill, because that loud noise would be very, very upsetting? Do they need to be able to leave if they're really stressed out and go talk to the guidance counselor with very little warning? Do they need to eat in the presence of the nurse or someone else who can make sure that they are not starving themselves? And above all, how do we keep everyone from making up a different answer when people ask why they were absent? Can we have, what do you want us to say? Do you want us to, whatever answer you want, we've got to make sure everyone's giving the same answer so that kids aren't going, ooh, there's something suspicious going on here. Okay. We also want to make sure that it's clear to the family what the school expects. Okay. The kid will come thinking that they have to do every scrap of homework that they missed, that they have to meet every upcoming deadline that is yet coming. Oh, I have to take that test the day after tomorrow, even though I haven't been here for the whole unit. So first of all, if that's what the teacher's saying, we need to talk to the teachers and help the teachers change that. I mean, you kind of got to picture it. If you had a kid who was moving to the district a third of the way through the school year, you would not expect them to do all the work that they missed in the first 2 or 3 months. Same deal. If the kid's been out for 3 weeks hospitalized, they should not, they need to be at level, but that does not necessarily mean that they need to do every bit of work that they missed. Okay. So we want to help the kid understand, what is the plan? What does the school expect? What kind of behaviors did they have before that the school really is insisting are not going to be tolerated? If you've got someone who has a history of cutting, what are you going to do about whether they are wearing long sleeves or short sleeves? Things like that. What sort of expectations, plans, rules, and support does the school have to offer? Okay. Whatever you talk about in the meeting, you end the meeting by scheduling a follow-up meeting. The problem is you end up laying out all these accommodations and stuff like that, and somehow that gets written in stone as this is all the kid will ever in their life be expected to do. It's like, no, this is the accommodation for now when you are newly coming back. If you got someone who's coming back after a lot of school refusal for anxiety, yeah, they might really need to be able to have some very vibrant access to an escape route when they get overwhelmed by anxiety. That does not mean that they will always, for the rest of their lives, should expect to be able to just leave class at the drop of a hat if they feel stressed, because part of healing from anxiety is learning to not need to do that. They haven't learned it on day one, but we've got to help them on a path towards learning it rather than having the accommodations last forever. Or you discover the accommodations aren't good enough and the family just bails and stops coming, or the kid stops coming. You need to be able to update the plan, either saying you're doing great, now we can help you do more, or okay, we need to be more supportive because it's not going so well. So keeping the communication open, not making it dependent on people saying we need to talk because things are bad. We want it to be just part of the process. Okay, so Charlie, remember how we were worried about what he was crying about in the bathroom? He didn't go to the hospital. The family came to pick him up. They said they were going to the ER, but then they didn't, and he just came back to school the next day. Or no, we have mobile crisis come and check him out, and they said, and the family said that is all an overreaction, and mobile crisis said, yeah, well, okay, he should go to partial hospital, but they didn't even call. Or they went to the ER, and the ER said, yes, he definitely needs to go to this, ART or CBET or another program, not hospital, but another program. We don't know. Maybe the family's following up, trying to give him a therapy. Maybe they aren't. Oh yeah, if it's therapy, you're like, wait, didn't we do therapy a few slides ago? Yeah, they stopped after just a month or two. So they were given a clear directive by the ER or by mobile crisis to do this care, and they've decided they don't feel like it. The family does not have a right to decline now. This is the fun, tricky thing, okay? The school can say till they're blue in the face, this kid needs care. And you're just a school. These folks are medical professionals. They say the kid needs care. The family's not accessing care. That's medical neglect. So now we can start actually putting more pressure on the family. But again, you want to do it carefully, gently, and with with the goal of success rather than just the goal of winning the argument with the family. Okay. So start off with, yes, your life is very hard. Okay. Yes, it's very, very hard for you to call all those therapists. It's so complicated. I will help you with that to a point. Okay. So you offer them support, but you make it very clear what the specific is. And then when you give it to them, I'm going to check back and see how it went. Meaning I will print out for you therapists that are in your area and take your insurance. You do the Google search, you print them out, you give them to them and say, okay, so you got to call these. I'm going to check in with you in say 2 days to see how those phone calls went. Okay. We want to recognize that whatever's getting in the way of them doing what they need to do is real. It might be that they're calling and no one's calling them back. It might be that they're not calling enough. Don't waste any brain cells trying to figure out whether to blame the family or the system for the fact that this kid is not yet getting plugged into care. In all likelihood, it's both. So just keep moving forward. Recognize the process might take time. So you need to have plans in the meanwhile. You might want to make your plans be kind of really annoying for the family. Not really annoying, but just annoying enough because they've got a really hard job ahead of them. You need to have doing it still be in some ways preferable to not doing it, whether it's that they just don't want to hear you calling them all the time, or whether it's every time he's acting out, they have to leave work and come and pick him up, and that's a problem. You find out what is it that will make them be more likely to see that doing what they're supposed to do is actually going to make life better rather than worse. Okay, so you need to make the goals stepwise, not you must achieve everything immediately, but you do expect that, have consequences if they don't. And one of the big consequences is that you could file a 51A for medical neglect. Hospitals deemed he needs this therapy. And so you want to, first of all, you've documented a lot of this is how you have been encouraging them towards it. So you're not saying, yeah, the hospital said he needed this 3 weeks ago and we just waited 3 weeks. No, it's we were working with them for 3 weeks. And this is why we think that it's come to this. Okay. And even before you're telling DCF that, you're telling the family that. You want to be saying, oh, I know it's really hard to do this, but the hospital said he needs this care. And if you aren't getting it for him, then I'm a mandated reporter and I'm required to report that because that ends up being medical neglect. So could we try a little bit harder now and see if that helps? So Charlie's in high school. He's doing so much better. He lives with his aunt now. Okay, so that whole DCF thing, it went fairly well. Okay, and his aunt is great. She makes sure he's getting to appointments, he's taking his meds, he goes to therapy, he's doing his homework. And so life has stabilized for Charlie. And as a result, Charlie is just as issue-filled as he was before. He is still blowing up. He's having angry outbursts. He's testing limits. He's punching holes in walls. It's kind of creepy because have you ever, raise your hand if you've met a kid where the more supportive, respectful, and caring you are towards them, it seems to really piss them off. And you become the one that they target even more than the people who are being mean to them. Where it's the one who cares about them the most is the one that they are going to target when they're losing control. It's a weird thing. And people are very what's up with this? It's a very, very common thing. Reasons for it? Definitely talk to the therapist, let the therapist be looking at this as well. It's a long, slow healing process. And part of the healing is facing all the pain that's there that needs to be healed. It might be that, yeah, with his parents before, if he said he felt bad or if he expressed anger, he was going to get the crap beat out of him. And she's the first person that he can go ahead and be mad enough to punch a wall and feel safe doing that. Or he might think that if he's mad, he deserves to be in pain and she's not hitting him, so he has to punch the wall. Or it might be that all his life, it feels like no one's cared about him because he's Charlie. He's bad. He's been bad from the first slide. He's the one who's always in trouble, never doing anything right. He's intrinsically not worthy of being cared about. And so that just makes sense that no one cares about him. And now all of a sudden, someone cares about him. That's confusing, because it's not just that he has to deal with her caring about him. He needs to rearrange the furniture in his universe to make room for that to be possible. And part of that means realizing that all those people before who didn't care about him, they totally could have. They just didn't. It wasn't that he's unlovable. It's that they just deprived him of something he needed. That kind of hurts worse than feeling like you're not lovable. You know, we had a stuck kid on one unit where he would target whoever his favorite staff person was. He was stuck there for a month, and we all adored him. And he knew that we all loved him, but no one loved him enough to take him home. That hurt. So he would focus on the person that he loved the most, and he would spit at them or throw something at them, because that way now it makes sense that they're not taking me home because I just spat at them. So of course they don't want to take me home, rather than just, yeah, I just don't get to go home. Or with Charlie, it could be that he really loves his aunt, and then he has to feel all bad about loving his aunt because he's supposed to love his mom, and yeah, it's a mess. Let the therapist work on that. What can we do to help his aunt? Okay, let's do some family stuff here now. Okay, for family supports, that means early and often and repeatedly helping them learn that it's okay for them to have needs. Self-care matters. Okay, they will probably say, no, I'm busy taking him to his appointments. Say, yeah, but you got to have your appointments too. You know, what did you used to do? How do you keep doing that? Did you used to see your friends once a week? What can we do to help you keep seeing your friends once a week? Let's crank it up. How can we get you your own therapist? Family therapy. Those would be really useful. But it might also be nice if you got to have a massage. Might be good if we make sure that you're getting your own meals eaten and not just feeding him. You know, so what can we do to help you have care? There are programs that have wraparound care that do try to help everybody in the family. Okay, there's support groups. Yay, support groups. It's really good if you can do the online search for local resources rather than them, because I've done this Google search. If you put family members and support in any search together, 95% of the hits are, this is how the family member can support their needy child. Which, you know, those are important. Yes, we got that, but it pretty much, any family member who's trying to look for support for themselves gets a big, huge dose of, what are you looking for support? You're supposed to be supporting him. And kind of feeds into that idea of, I shouldn't need help. I'm supposed to be helping him. So it's really good if you can do that instead. Some resources that are really good are NAMI, National Alliance on Mental Illness. They have lots of family supports, and they've got support for people with mental illness. They've got lots of regional, local things, different age-specific things, diagnosis-specific things, and so on. And there's also the Parent Information Network, which is the Southeast Massachusetts version of what I know as PPAL. Don't ask me what that acronym stands for. Terrible with acronyms. Anyway, those are two resources in the area that are very good at helping parents hook up with other parents who are in the same position. If you want to be starting something for parents, that's a wonderful, wonderful thing to do. Make it available and be very, very patient and bring food. Do not be surprised if people end up canceling frequently at the last minute, because as it turns out, the need for the group is often interfered with by the reason why they need the group. Things come up all the time. So Charlie's made it through high school. Go aunt. Yes, he's graduating. What the hell is going to happen when he graduates? Okay, the end of high school is really kind of hard for everyone. Okay, transitional age is not anything that people are like, oh, did you remember your transitional years? Weren't they just fun? No, nobody likes that process. Okay, it's hard. It's extra hard for some people. Okay, the stigma associated with mental health and or ongoing symptoms can make you feel like you've got very limited options. You know, my daughter had OCD. We were not worried about her being in college and managing her OCD, because she was managing it very well. She had a really bad time in the middle of high school, which meant, of course, her grades went down and went back up. And the college essays all asked for students to write about something that they've accomplished. She's like, well, the hardest thing I've done in my life has been exposure and response prevention for OCD. My God, that's painful. So she wrote about facing and dealing with OCD. And she got rejected from every damn college she applied to. Some of them were above reach. A lot of them were safety schools. No one would touch her with a 10-foot pole. So she got to sit through her senior year watching everybody else talking about going to college. The stigma is so infuriating. And even aside from issues like that, all kids are dealing with, how do I feel independent when I still have needs? I need them to take care of stuff, but I want to be independent. And yeah, most of them navigate it just fine by expecting the parents to pay for everything while they get to stay out all night if they want to, because they're grown up, So most kids don't really have cognitive dissonance with that, but when you got a kid who's been through the ringer like this, it gets really messy. If you've got a kid who is behaviorally disturbed and not with their family of origin, they got to be terrified. They've been terrified all along that this adoptive family is going to dump them if they are too much work. Everything the family does to try and help encourage them towards independent living feels like dumping. Teaching the kid how to pay their own bills walks right into the corner of their brain that says, you just can't wait for me to leave, can you? So it's really, really hard. And a lot of kids with issues live in a very transactional world where if I give you something, you owe me. And so it's really hard for them to navigate. If I need help with what I'm doing, how do I deal with the obligation that carries? My oldest daughter came to us through foster care, and the number of times we have offered to pay for something and she's been like, no, like, come on, let us, we're fine with that. And she's still, she does ask us for stuff. It warms our heart, the rare occasions when she's willing to actually accept something. And she knows that we wouldn't expect anything in return. She knows. Other than my occasional jokes that she's the most stable one of my 3 kids and she'll have to take care of me when I retire. But other than that, she knows that it isn't transactional, but in her gut, it feels transactional. So these are complicated times for any kid, but especially for kids with mental health issues. We want to help whoever is raising this kid to anticipate and eliminate unnecessary additional problems because they got enough intrinsic ones, okay? Start with that wonderful age gap. If you are trying to find a therapist when you are 18 and a half, you're screwed because you're too old for a pediatric provider and you're too young for an adult provider. So by the time they're 17, you want someone who does both teens and adults so that they will not have to go and find a new therapist in the middle of that process, unless, they're moving. That might make sense, but, you want to make sure that's covered. If they have come through foster care, DCF, and the guardian or adoptive family or anyone has been told what they can expect the kid to be entitled to upon turning 18, get it in writing repeatedly and expect to have to call DCF and remind them, because it's a big bureaucracy and sometimes they drop things and your kid turns 18 and suddenly her Mass Health card doesn't work anymore and everyone forgets that they were supposed to give her tuition until she's too old to get it. Things like that happen all the time. So help them navigate the bureaucracy proactively so that they can advocate for things continuing as they're supposed to. That oldest daughter, she's become guardian for her brother. He is definitely getting everything he's supposed to because she knows what to make sure they do not drop. Okay, for support services, there are a couple programs out there. MGH and McLean both have specific programs for college transition. Aimed specifically for kids who have mental health issues and want to go to college. Help them navigate the stigma. If they need accommodations, how do they deal with their symptoms? How will their symptoms potentially change in different situations and so on? How to deal with that. And there are lots of other programs out there as well. DMH actually puts out a really nice handbook. So that's definitely worth checking out. Okay. But the really hard thing for the kid to wrap their mind around is accepting support does not mean that they now control you and own you and you have to do everything they say. But that doesn't mean that you get to do whatever the hell you want. It's like, okay, if they are paying for the cell phone, it might kind of make sense to them to not be happy that you are using the cell phone to not go to class, or anything like that. If they're paying for the car, then maybe you should actually show up for work, things like that. So, and helping people learn how to navigate that sort of give and take in a healthy way rather than in a dysfunctional transactional way is the fun job for that age. So to summarize, this is a system we have, okay? There's really nothing to be said about, nothing useful to be said about deserving or wanting better. Of course we deserve better, and of course we want better, but we got to deal with what we got, okay? Any list of resources that you have in hard copy format is almost certainly not current, but it still has some things on it that are current. Just be prepared for things to be out of date and see if you're setting up a list, it can be set up in a manner that it self updates itself as much as possible, or that it's very easy to update, or that there's a clear process plan for it to stay as current as possible. Communication is the most important thing in all of these stages, okay? Never assume that anybody else knows what's in your head, okay? People will all the time be like, well, but of course that's what's expected. It's like, no, they might not know what you know. They might not, you'll have the teacher who dealt with the kid in the classroom, pass the kid off, and then the nurse is the one talking to the ER, and the nurse knows nothing about what happened in the classroom because the teacher naturally had to get back to the classroom. But if the nurse doesn't have the information to pass on to the ER and the ER doesn't have that information, they're not going to give an answer that you might agree with. So never assume other people know it. You need to be communicating as much as possible appropriately. You also need to protect privacy appropriately. You got to work with what you got, okay? Lots of times you're like, oh, this family? It's like, yep. But that's the family. That's the family you got. So this is what you need to do. Help them be as good as possible, okay? We want to recognize, tell yourself multiple times a day, whoever is frustrating you the most right now is doing the best they can with the skills, time, energy, and resources they have available to them. It might not always be true, but it will do wonders for your mental health to assume the best of intentions from everyone around you. Like DCF, if you've ever gotten really frustrated by DCF system, near as I can tell, is they take a social worker and give them some cases. And if they do a good job, you got one who's doing kind of a mediocre job and one's doing a good job, you give the good one more cases and you keep piling on cases until they're now doing a mediocre job too. And thus, because there aren't enough social workers, there's just not enough system out there for the system to be anything other than what it is. So accept that everyone is doing the best they can with what they have. If you got anything more you could give them, information, reassurance, respect, do so, okay? Always try to focus on common ground and shared goals. Too often we get into a fight about, yeah, but lots of times we're blaming everyone, getting into a big fight over who to blame for what happened in the past. Say, okay, let's look at the future and what is a future we can agree to. If you've got this kid is just doing this and this, well, we agree that we want him to be able to graduate. So let's make some decisions that will move him towards graduation. Or we agree that you want him to be able to go to school so you don't miss so much work. What are some things we can do that are moving him towards that goal that we share? And then don't let the perfect be the enemy of the good. Don't be so busy recognizing and pointing out and highlighting how broken the system is to decide that you're just going to stand there and hold your breath until we magically get a better system. So when something is half as good as it ought to be, recognize that's still a lot better than nothing. So as I said, there's all these resources, but I've already sent you all of them, including, I always have a thing of videos, because I know these guys have some really great trainings that are really cool. But then there's also, let's see, are any of these videos? Yeah, down here we got some videos, because sometimes you really just want to sit and watch things, okay? And I'm pretty sure This American Life is about a family that adopted a kid from Russia when he was 9 and how they helped him. And it's an amazing, amazing story. And when they asked the keys to their success, the 2 keys were, they did not take it as a rent with an option to buy. You know, they were like, yeah, we're keeping him. Of course, what do you mean? You know, it never crossed their mind to bail at any point. And they appropriately lowered their standards. They weren't like, I want to have a kid who's lovey and thankful to me for rescuing them and hugs me and is effusive. No, they're like, I want my son to have a good life. I want him to reach a point of being able to relate enough to have a good life. And so lowering the standards to focusing on the kid's future instead of wish for the future, you know, the perfection that they'd hoped for in the first place is good.
I had a question. I was wondering, what is the difference between CBAT and ART, or are they the same?
Near as I can tell, they're the same.
Please.
Okay. Yeah, ART is acute residential treatment, and CBAT is community-based something treatment. I hate acronyms. I know that the ICBAT is CBAT with a few more, like more therapy or somehow slightly more intensive. I think in Framingham, there's a place that's got a CBAT and an ICBAT, and I read the descriptions of the 2 of them. But when people describe, you know, I've had kids who go to a CBAT, and then when they need to go someplace again, and the family is like, we recognize that they need to go someplace, but we don't want them to go to the same place they went before, either because it was bad or because it was really kind of comfortable for them there. And they don't want the kid to get just so comfortable. That's one of the things that's really hard, is that when you are inpatient or in a residential like that, you can be like the most stable kid on the unit. You're the one who actually knows how to do things. And you are the one with the coping skills. You are the go-to person who is really on top of the issues and how to deal with your issues. And everyone is so proud of the hard work you're doing. And then you go back to public school and you're the broken one. You're surrounded by people that you blithely assume do not have issues to manage. And the fact that you can manage your issues really well is not impressing anyone. In fact, you're probably trying to keep it secret. And that's a really hard transition to make. So one of the things when I hear about a kid who's really struggling and they're like overwhelmed, one of the suggestions I make is there any way you can give them a job helping someone smaller? You know, obviously if they're like overwhelmed and violent, that doesn't go so well. But lots of times it's that they feel incompetent. And so finding any part of their life where they can feel competent can be nice.